So-called stable VT is often a classic high-risk clinical scenario. Stable VT is a diagnostic trap where the patient's BP looks reassuringly stable, but the electrical substrate is a ticking time bomb. For a clinician, the primary challenge is overcoming the stable VT is equal to non-urgent impression. Here is a breakdown of why hemodynamic stability is often a false friend in the setting of malignant arrhythmia. Hemodynamic stability is a snapshot in time. A patient may maintain a BP of 110/70 during VT due to robust compensatory mechanisms like intact sympathetic tone, preserved ejection fraction, or a slower rate. But this does not mitigate the underlying risk. Rate versus stroke volume. Even at a rate of 150 beats per minute, a young or relatively healthy ventricle can maintain cardiac output. However, the loss of atrial kick and the dysynchronous contraction eventually lead to myocardial fatigue. The threshold of collapse. Hemodynamic collapse in VT is often sudden, not gradual. As the myocardium becomes ischemic from the tachycardia, the stability can evaporate in seconds, transitioning into ventricular fibrillation. When the patient is talking to you, but the monitor shows a wide complex tachycardia, the temptation is to call it SVT with aberrancy. This is where the Verrecke or Brugada algorithms become vital. AV dissociation. The presence of P waves marching independently of the QRS is pathognomonic for ventricular tachycardia. The exception being junctional ectopic tachycardia, but that is a narrow QRS tachycardia occurring in a different setting. Capture and fusion beats. These are important pointers to VT, proving that the ventricles are being activated from a focus within the chamber. Concordance. If all precordial leads V1 to V6 are either entirely positive or entirely negative, it is almost certainly VT. Stability does not change the substrate. If VT is occurring in the setting of a scarred myocardium, like prior myocardial infarction or an ion channelopathy, the electrical instability remains malignant or ONT phenomenon. Even a currently stable VT can be interrupted by a premature ventricular contraction from another focus, triggering a descent into ventricular fibrillation. Troponin leak. Sustained VT, even if stable, causes subendocardial ischemia, further lowering the threshold for more lethal arrhythmias. The most dangerous mistake is treating stable VT as SVT with a calcium channel blocker like verapamil. In VT, verapamil can cause profound vasodilatation and cardiovascular collapse, turning a stable patient into a code blue. An exception is fascicular verapamil responsive VT, often called Belhassen's tachycardia. Clinical rule of thumb is, in a wide complex tachycardia or wide QRS tachycardia, if the diagnosis is in doubt, treat it as VT. Key differentiators for a malignant VT. QRS width more than 140 milliseconds in the RBB pattern or more than 160 milliseconds in an LBBB pattern are more likely VT. In SVT with aberrancy, it is not that wide. Extreme axis, northwest axis, more likely VT. In SVT, normal or left axis. Response to adenosine, no effect usually in usual types of ventricular tachycardia. In SVT with aberrancy, there is either conversion or slowing. Structural heart disease, history of previous myocardial infarction or low ejection fraction, VT is more likely. And such a history is often absent in SVT with aberrancy.